I want to talk to you today about sleep, which is a topic of interest of mine. And this is a project that started 3 weeks ago. It's a 6-year, multi-million-pound program. It's the largest sleep study ever funded by the NIHR in dementia. And it's personal to me because the pandemic affected my sleep badly, and I'm still probably recovering from that. And we actually got this funding during the pandemic. But it goes back also linking it to Brighton and Naji. I used to work in Kent as a consultant, as Naji knows, and we were interested in sleep together with melatonin many years ago. And we had a failed research for patient benefit bid looking at a drug called melatonin. But I didn't put sleep to bed. I kept it at the back of my mind until we sort of developed further work. So what we're going to talk about today, if I can go to slide 2, please, is sleep, because it's important in general. We all need sleep, and it's really important to think about that. And many of the lessons from this talk will apply to anyone of any age, but I'm going to focus the lens down into dementia as well. That's part 2. And I'm going to bring in prevention, because we've heard a lot about prevention, and I think sleep is a key part of that, and it's hugely exciting, its potentials in preventing the progression of cognitive decline, but also the onset of dementia. I'm going to present some of our early work from 2020, which is epidemiology, again, looking at the harms of medication, and that was part of the key foundations to us getting this project. And then I'm going to show you the prototype. So this is based on COVID assisted this project in a way, because there was a system set up called COVID Protect, which I will show you. It's an NHS digital system, and we're going to be using our intervention to replace COVID with time. So in other words, as I heard the other day about getting vaccines done, we've supercharged perhaps trying to solve primary care sleep disturbance in people with dementia and MCI. And then I would reach out to the research community, because we're setting up some international and national sleep advisory panels and carers. So if anyone wants to reach out to me at the end, my email will be at the end of this talk. So next slide, please. So this is a bit of basic background, which I'm sure we've heard. I haven't been at all this great conference, unfortunately, because it was in the middle of my clinic. So I was dropping in and out. But we know that dementia is growing. It's predicted to escalate by 2050. And there are significant numbers of people affected still by dementia. And sadly, despite Biogen's best efforts, there hasn't been no great breakthrough yet, but there's an exciting pipeline coming. So maybe there'll be a medication route. So in the meantime, we have to think of other things. And the other interesting part of the talk is, I keep referring to MCI. In this program, we are looking not just at dementia, at MCI, and I think it's important to highlight that as a potential target for prevention in the sleep field. But there are about estimated 2.4 million people in the UK suffering with MCI at any one time. That's based on some of our own data, but also some epidemiology data. It's rough and ready, but it shows that that is a significant problem. Next slide, please. So in terms of general sleep health, about 1/3 of working age and half of older people will report some type of sleep disturbance. And I used to think, until we got involved with this project, it was just about lack of sleep. But there is also other types of sleep problems. And I'm going to give you a little pen picture in due course about those problems, because they are important. The prevalence of diagnosed sleep disorder ranges from 5 to 8%, and reported sleep problems are very high, as you can see in the population. And it's quite astounding. We've got quite a senior health economist on this program, and she saw my slides and said, "You don't know health economics. Look at what it's costing the US." She found this really good paper on incremental costs. I mean, that's absolutely astounding. $94.9 billion incremental costs of sleep problems to the US population. So if you scale it up globally, it is a huge cost. And those costs are complicated. It's about employment. It's about healthcare costs, social costs, and healthcare costs are a huge driver of this. Not necessarily just the sleep, but it's the complications from the sleep, such as hypertension, falls, etc. Can we move on to the next slide, please? So what about sleep and MCIs? So you look at the prevalence figures in the epidemiology. How common do people with sleep problems and dementia present? And it was quite interesting when we were developing this project, we spoke to a significant number of carers and patients and GPs. And the GP said, well, people don't come and see us about sleep. They come to us because they're worried about a physical health problem, they're worried about agitation, or they want a diagnosis. And we asked them, well, do you actually ask? And they said, well, no, we don't actually. And it's a very good point. So that immediately sort of unplugged a potential area of interest for research about the assessment in primary care and secondary care and signposting. And that perhaps explains why there's such wide variation. But it's common if you ask patients with dementia, how do you sleep? There is often a problem, almost as much as agitation. And it does go hand in hand with some of the things that my good colleague, Professor Banerjee, was talking about with challenging behavior and neuropsychiatric disturbance. It has a significant effect on day-to-day activities, driving, even in MCI. Patients report sometimes that some patients that we worked with on developing this project, young onset dementia, young onset MCI, describe that it affects their ability to go to work some days. And if they're on medication, it has a significant safety impact. It's also associated with poor daily functioning, and there's a strong link and association with agitation, behavioral and psychological symptoms of dementia, etc. Disrupted sleep is also a chronic issue, and you have to think of the carer. That's another very common issue. Often when the person with dementia hasn't got a sleep problem, you'll find the carer has because they're worried. And that can be a carer who's living with them or even a child or a more distant relative. Next slide, please. So what's the cause? This is direct from the bid. I just cut and pasted it in a way and then adapted it and tweaked it. Now, you could say, is it chicken and egg? So is it that they have a primary insomnia and then they develop dementia? Is it other things? And what I'm trying to show here is the complexity of the issues. And I've tried to summarize it. I'm not going to read every single part of it, but we've got age-related changes, and my slides will be available, by the way. We also have psychological disorders, and we heard about from the previous speaker about the role of depression and anxiety and the development of dementia. Commonly, sleep is tied into those. The medicine side effects, I've had patients stop Alzheimer's drugs because of severe nightmares, and we've been through every single one, and they've then momented, and every time we've stopped it, it's gone away, we've started it, and they came back again. So that can occur. Comorbidities, very commonly associated. Patients with dementia very commonly have multimorbidity. We are doing a medical research council project at the moment in that very area called Gemini. And it all seems to link it up and make it very complicated. And then we've got environmental factors. I just flagged pollution in there because we've got obviously noise and heat, but if you're living in a polluted area, then your breathing can be affected at night. That can then lead to sleep disturbance, et cetera, et cetera, et cetera. So these are important to consider. And all of these things, I think, linked as many of the things that the speakers in the conference so far have been talking about, with the sort of complex biopsychosocial aspects of dementia. And then we've got activity, which includes daytime napping. If that happens, that can destroy your nighttime sleep. Next slide, please. So what about the types of sleep problems? They are complex. I'm not a sleep expert. I'm a psychiatrist. I'm forever learning about sleep problems. You've got the main sleep problems in this slide, but it's very interesting. The top line I just took out that the more sleep problems you have, the greater the risk of developing dementia and cognitive impairment. And obstructive sleep apnea is a very common condition. And in fact, there's some work from UCL which has shown that it's highly prevalent and underdiagnosed. The reports of 60% of people with dementia may well have obstructive sleep apnea, which was quite shocking when I heard about that. But then, it kind of makes sense if you don't look for it and if you don't know what it is. And if you speak to the people in the sleep castles, I call them, sleep physicians, sleep experts, they seem to think that primary care should refer them, but then they say the tools aren't necessarily fit for purpose. So there's a sort of perfect storm of, okay, forget dementia. Obstructive sleep apnea on its own is difficult to spot. Questionnaire is not particularly sensitive. If you add in dementia there, then it makes it very difficult to then target those patients to the relevant intervention, such as CPAP, etc. Next slide, please. So what about the possibility of preventing dementia by curing sleep? Now, I'd be crazy just to think that sorting out sleep would stop dementia, but clearly there is evidence that it is a contributor to the modifiable risk factors. I just highlight three studies there. There's a French study, which is the SYNAPSE study. There's an atherosclerosis study and then an osteoporosis study. The bottom line is the evidence is a bit all over the place. But in the first osteoporosis study there, you can see there was quite a strong signal, and it's quite an old study this, in ladies with an association of onset of developing MCI and dementia and obstructive sleep apnea. And then a follow-up linked studies by Yaffe, more recent, again in men, showed a decline on the MMSE, but again, it was a bit vague to say whether they actually developed dementia. We move on to the atherosclerosis risk study. And again, there was no association, but they did say that if you had severe obstructive sleep apnea, then you had a significantly increased risk of dementia. And the last one, the Proof Synapse study, 8-year follow-up study of people with obstructive sleep apnea, only attention seems to be a problem over, which is a persistent problem, which kind of makes sense. So if we move to the next slide, this is a sort of summary of the relationship, and I've picked obstructive sleep apnea because I think it's very common, a problem, and may well be a target for people to look at in future studies. There are, as you can see there, we've got some of the modifiable risk factors going down the left column. On the right is if there's any studies, and you can see it's the usual thing, ApoE4, there is a study in association between obstructive sleep apnea. Menopause, there are no studies, very limited studies. That's a bit, we're going to be hearing about that later, but there's a particular link there. So these are potential targets for future studies in prevention, linking in sleep, in my view. Next slide, please. So what about medication? We all think that, we've heard earlier today that we shouldn't prescribe medication for agitation and dementia. Well, I wish I had a t-shirt to say you shouldn't really do it for sleep either. But we did influence NICE with our submission about the use of sedatives from this project. So the project I'm going to talk about in the next few slides is a project funded by the HTA called the Z study, which we published in 2020 on the harms and benefits of using sleep medication in people with dementia. It was a CPRD and CFAS study, linked with many of the authors that others have talked about from Cambridge. And it was a multi-center, large-scale study. But the background to that was we recognized that these drugs were being used. At the time we started putting in for the Z study, people were fleeing from antipsychotics because of the great work from Professor Banerjee and trying to use other medications, including antidepressants and sleeping tablets. And there was a spike in the use of Z drugs. So the NIHR thankfully agreed to fund us to look at this question. But go to the next slide, please. So what we found was there was a significant number of hip fractures. There was a 60% increase in the risk of hip fracture if you take one of these drugs on the right, which are so-called Z drugs. Hip fractures increased by 3% a year with Z drugs, and in any event, there was a difference between 3 and 5%, as you can see. However, more interestingly, people's memory, and it didn't improve if they had a good night's sleep on these drugs. And that has a physiological reason for where they work and how they refresh sleep. They're actually not benefiting the most or the best stage of sleep, which is non-REM. Often they are suppressing the REM sleep stage 2, which has a significant impact. And there was no benefit in this epidemiological study on the quality of life or any reduction in behavioral disturbance, which was quite a powerful finding to stop people fleeing from antipsychotics to then sleeping medication. Next slide, please. So one of our other parts of this study, which was partly supported by the Alzheimer's Society as well as the HTA-Z study, was the relationship between do sleeping medications, benzodiazepines or Z drugs cause dementia. There is a lot of sort of associative data saying that it may well help, may prevent, may cause. We didn't really know. So we looked at a post-mortem study. I think it was about 300 brains in the end with Paul Francis's group and Carol Brain and people from Sheffield, and we couldn't find any real association. We did find there was an increase in use of benzodiazepines with people with dementia, and there's a potential greater loss in the nucleus basalis, but it wasn't seen as that significant on its own. So the conclusion from this study was that people with dementia do use more benzodiazepines as a reaction to perhaps behavioral behavior that challenges. But also there was this pathological impact on the loss of the nucleus basalis, which may well relate to other things and could be part of a dementia progression story, but it was uncertain. Next study, please. The next slide. So to look at just the key findings from the HTA study, then we found that a hazard ratio for fractures, falls and stroke was 1.6, 1.96, 1.33 and 1.88 respectively for those different problems. So there was an increase of fracture, hip fracture, falls and stroke if you take Z drugs and have dementia compared to those patients not on that, based on CPRD data. However, if you took the dose to less than 3.75, the risks fell away significantly for mortality, infection, and DVT. So low dose seemed to have some possible sort of assistance with morbidity aspects and harm, but still was an issue. And there was no difference. This is the sort of old wives' tale that Z drugs were always safer than benzodiazepines. There wasn't anything really different, apart from there was a lower mortality rate, less death with Z drugs than benzodiazepines, but everything else was exactly the same with falls. So with the background of that, we sort of thought, okay, so we've got people, what do we prescribe? HTA-SAD was coming out. We knew vaguely about SIMBAD results. I started to think, what do I tell my GPs? Like we saw with the questions, what can we prescribe? Every drug seems to be dangerous. I've got nowhere to go. And patients are presenting in primary care with sleep problems or linked to agitation. What can we do to the GP? How can we help them to overcome this problem? Because we were still getting patients given antihistamines, still turning up at clinics and high prevalence levels of sedative medication. We're going to show you some data that we actually got from NHS Digital during the pandemic on use, which is quite interesting, and I think was quite a sort of convincer for the NIHR to sort of support our endeavours. Next slide, please. This is just before we do a slide of the impact of different medications on the different aspects of sleep. And it's interesting, our sleep physician lead said, he said that the biggest problem he sees in older people is people coming to him on dithiopin amitriptyline, which is basically, that seems to be a lot of what his job is about. They get referred, GPs give them that, not knowing that it destroys the best part of sleep. So it is basically a REM suppressor, which is really, really bad. And that then aggravates the whole problem. And people aren't really widely aware of that. I didn't know about this, neither did half our non-specialist physicians, and the GPs didn't know either. So it's helpful to have this sort of slide to see where the sort of medications are benefiting. And I was struck also by the ketamine also seems to be a REM suppressant. Not that we can use that so much in people with dementia or older people yet. Who knows if someone's going to do a trial. And then some of the ADHD medicines are on this, such as atomoxetine is mentioned as well. So that seems to have some adverse sleep problems. Again, it's related to an antidepressant, but it's mainly used in ADHD. Not that this will come into dementia patients, but it just shows the complexity and yet what is the ideal drug. I mean, mirtazapine, if you look at it, is on there. We've talked about that with SINBAD. As you can see, it's neutral on the REM sleep. So that may explain why it does seem to be helpful sometimes in some patients who need sleep in general adult psychiatry, old age psychiatry, or in the community. People with dementia, well, we've heard about about the results from SIMBAD, which I was part of, and that is another sort of warning. What do we do? So that was maybe considered a go-to drug as a result of us saying no to Z drugs, no to benzodiazepines, others saying don't use antipsychotics. Where are we going to go? And antihistamines, of course, are quite sort of nasty as well in their profile. So we're going round in circles here about which drug. Next slide, please. So this is data we put in the bid that we had access to. So we work closely with a very large provider of NHS Digital sort of services in primary care. And we asked them the question, how prevalent are use of these drugs? Because if there's only one person in a million, then why would they be interested in this? And the time study is not just about medication; it's about safer management. But we had to sort of justify, to some extent, the medication aspects. And it's quite interesting if you look across. So this is across about 400,000 people with dementia and MCI. Dirty data, but from 2,000 practices. The actual data set is 28 million. And this is the data set that we sort of going to be working the sort of project on. But about 6% of home dwelling people with dementia were prescribed at least one sedative hypnotic medication at the time of this snapshot, and 11% were taking more than one. And then we looked at it over 3 months. So they seem to be on continuing repeat prescriptions. That's what the data seem to tell us. They weren't just one off 28 days. These are people left, and it seemed to be over that 3-month period they were taking it. Now, this was in the pandemic, and we recognize there is a spike, isn't there, in the use of sedatives. And interesting, the care home figures were even higher. This is what we class as sedatives. We went for everything. So antihistamines, antipsychotics, antidepressants, you name it, anything that might have a sedative link to it. We could drill it down further, but it was quite sort of prolific in the care homes compared to the community. And then we know, I think this is Professor Howard's published study during the pandemic from NHS Digital, where they found that 10% of people with dementia were taking antipsychotics. It slightly increased. It was quite alarming why that was. And we've heard from Professor Banerjee today some of the sort of thoughts around that, and I completely agree on that. But the other thing that we found with the work with Dr. Maidment from Aston was that the fleeing to antidepressants was still occurring. And as we've heard earlier today, the use of sleep-inducing antidepressants has questionable benefit in people with dementia and cognitive impairment, and may well have harm, as we saw with the sort of mortality figures, although non-significant, that were reported in the Simbad trial. So next slide, please. So what's the suggested solution? So after reviewing the literature, doing all of our epidemiology data, working with patients and carers to co-design this, well, we recognize that this is a persistent, it's a problem in primary care. Often patients and families come to the GP beforehand, they've tried other things. And one of the things I was struck by, and it still rings a bell, and I think the PPI member may well be at this meeting, she said to me, one of the carers said to me, don't stop the antidepressants. That's maybe all we've got, because mental health has discharged us. The GP doesn't, my GP doesn't really know how to manage this, and it may well work on some cases. And that really struck a tone with us. How can we safely treat sleep with or without medication? And sometimes it's okay to prescribe. And that's something we call a wicked problem. Now, wicked problems are where a problem where there's no perfect fit. And as Subi said, that if anyone says they've got the answer, then they're trying to sell you something. And I'm saying with this project, we designed this thing about a complex, wicked problem with not a one size fits all. You have to work in collaboration with patients and carers, and using big data. That may well be the solution, because GPs haven't got time to spend an hour with a patient or a carer going through the problem. And that's where data and informatics can help, perhaps speed things up and allow the GP to make more informed decisions for need to then jointly decide what to do as such with sleep. The other thing about our sort of lesson in developing this project is that there was a need for follow-up. It's very difficult at the moment in primary care. I mean, I tried to get a GP appointment the other day for something, and I saw the paramedic, and I said, I'm professor of psychiatry, blah, 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 blah. And I went to see the paramedic, and I got excellent service. And I think it's in the NHS, we have to think about seeing a doctor isn't necessarily always the answer in primary care. And there are other members of the primary care team who, if we can provide them with the right tools, could provide a service to people with dementia and MCIs if they've got the right skill set and tools, which is another part of our development. Next slide, please. So the key consideration for optimizing management in primary care were, and this has come from work from Professor Joanne Reeve with the Taylor project as well as our own, trust is a big issue. Do I trust the person giving me the advice, either in mental health or in primary care? And that's key, and continuity where possible. The other thing is to minimize contradictory advice, and reading the Daily Mail versus talking to the psychiatrist versus talking to the GP and then going to your pharmacist. You can get different stories, and then people end up confused and they don't know what to do. And that can then aggravate the sleep problem in the carer, but also potentially the patient, and cause disaster. So it's trying to minimize, to optimize that. Monitoring and reviewing if necessary, and having smart monitoring. So not everyone needs to be seen again, but if you can develop a system which targets those, hence the precision health angle, that would be great. And then recognizing the symbolic importance of medication. As I've said, I was really struck by that. Literally someone begging me to not say, stop all drugs, please. And in certain cases, it's okay with these safeguards. And I'll take the risks, and so will the patient, the carer, etc. So managing that thing is complex, but I think really important. Next slide, please. So what about assessment? Just quickly, it is very complex. There are so many scales, hundreds of different sleep tools. You can send someone to a sleep lab, but they're generally not very nice. We've got a new one in UEA, which is quite pleasant, but it's only one room, and we could do with a bigger one. Surrey's got an excellent sleep facility as well, but it's difficult. Not everyone can get into these sleep facilities. There is limited availability. So is there a smart way to manage this and improve this? And this is another part of sort of our consideration in our co-design aspects. And whether there's a tool or a prompt or a device that could be linked in, the organization we're working with allows people to link their iPhones, their smartwatch, their Android Galaxy phones that can collect data, which could also then improve sort of management and develop an algorithm. So when the GP sees the patient or carer, he's fully attuned. He knows what's been happening the last few months and can use that data to make maybe optimal decisions, but we'll see. Move on. Next slide, please. So what's the solution? Drum roll. So this is just the start. And I hope in 5 years' time to come back with the bands and everything fantastic, but I'm always a cynic, so we will see. This is what we are going to be doing in time. So time stands for tailored management of sleep. Next slide, please. And there it is. It's deliberately small, but that is kind of what sits in front of a GP on their desktop. At the moment, this is happening today across 2,000 surgeries, 27 million patients, not Times, but they get this sort of system presenting. So it's a smart AI-based software system that works across the board, EMIS, whatever, and allows the GP, pulls in priority information to then allow them to make better decisions. And it also prioritizes the patient. So I think patients with dementia should be prioritized, and so does the system. So it will bring that in and link in their other medications, how many hospital visits, any smartwatch data, etc. So we're piggybacking on this. This has been running for about 10 years, is an existing NHS primary care system across about a third to a half of it. But the beauty of Times is it will fit in any system. So we've built out redundancies so it can fit in any practice ultimately in the future once it's finalized. And as you can see, it has defined patient groups, there's healthcare data brought in, it integrates across charities, councils, CCG and NHS 111 emergency services, etc. Next slide, please. So the defined patient cohort in this case will be those with sleep and cognitive impairment aged 18 plus. This is kind of the early trial bit, and we're going to opt, there is coding for MCI and there's definitely coding for dementia. We're debating whether to sort of say 18 plus, not related to head injury, and to do it that way, because coding is a problem in primary care. It's fully automated the way it links all the data. And you can see an example here. This is a mock-up, it's not reality, and there it would have things like tests, admissions in previous period, and alerts. And when you click alert, you would get the patient has an uncontrolled asthma, their sugars have been really bad, and that would then alert the GP. So it prompts to sleep. What is the relationship between diabetes and sleep? Now, we know that hypos and diabetes can cause sleep disturbance. So it's kind of a smart tool for then the GP to sit down with patient carer or talk to the care home and use that to optimize the management. It can be very fast and extremely efficient. It can also come up when they attempt to prescribe. It comes up with an alert. Do not give this patient mirtazapine because they're on warfarin, for example, or citalopram because of the interactions. That's the sort of part of it. Next slide, please. So here's a sort of a closer look at this, and this is from the COVID Protect system. It's not real data, but it's a kind of mock-up if you were a patient. This is what actually was happening in the real world. It protected 100,000 patients across Essex, Suffolk and Norfolk who were seen as vulnerable. So basically, these were seen as a special cohort. So it cohorted them during the pandemic, the first major lockdown, and was alerting the GP proactively to requests, any contact with the hospital services, any other. It was all interlinked across the sort of healthcare system, pulling data into the primary care system. So the GP could actually turn up on a Monday and he would get a screen with a number of cases where there were concerns. So under COVID, if someone had not come for their, I don't know, INR check, or they were out of date with their prescription, it would bring that patient because they were cohorted as highly vulnerable, very special, needing intensive care. And it kind of did protect about 100,000 people. Allegedly, there was some mortality effect. It wasn't a research platform. This was actually a service delivery. But we think what we're going to learn from COVID is we're going to put Times onto that and more. So the pandemic did help sort of show the power of this. And now we're going to sort of focus this down onto sleep in primary care. Next slide, please. There's also, but the important part is it's not just digital. There is a patient portal. This is the COVID Protect one where it says hands, face, 2 minutes. If we can remember the regulations, because this has been changing up around the center. But what the patient could do themselves or the carer is log in with a code, and then they would go to another face. So they would get a picture that was more lay friendly as the GP saw on the previous one. So it would say your blood pressure medication is due for review, your blood pressure needs checking, your warfarin needs this, you haven't had a memory test recently to see if the memory drugs are working, please book in. So it was kind of a smart screen for the carer, the care home, or the patient, but also it would all be printable. So the patient, it could be mailed to the patient. So in the event the patient does not have digital access, because we have to think about inclusivity, the system automatically creates a letter which can go and with some prompts and advice and suggestions. So it sort of kind of crosses technology and sort of more sort of historic techniques, including paper. And it's got basically smart AI algorithms around it. So we're not developing those, we're adding on top of those with this particular project. Next slide, please. So what is Times? Because I probably confused you all with COVID Protect and all this COVID stuff. So Times in essence is a system based on the patient's primary care records to help the patient the family member if appropriate, the primary care team make the best decision. Whether that means they take on the management themselves or fast track them to a sleep lab or fast track them to a cardiologist, this is what we're trying to do. There's that gap, as Subi talked about, with how can we help GPs, what can we do, how can we make them smarter, and in the end, how we can get more appropriate referrals to Naji and me in my clinic, so we're not overloaded with patients as we are at the moment and swamped. And sometimes we think, could primary care, could another service have handled that? Maybe that's naive, but I think that's important to sort of consider that. The other thing, it's patient and carer facing. Population we're looking at is in dementia and MCI, and the setting is care homes, not hospitals, unless people happen to go into a hospital, and also in the community. And the other thing at the bottom, which has been cut off, is it's using big data to make smart decisions, which is important. So it's using the power of those 27 million patients and all the data, because the system's constantly learning, mixing, and sort of coming up with suggestions. Can that optimize the best care? So there's a huge, I suppose, machine learning, big data, multi-system background to this. So we'll design this thing, sit it on there, but it'll get fed information from primary care records and safe alerts with drugs, etc. Next slide, please. So it started in February, feasibility late 2023, very large trial, 1,000 patients across about 110 practices. We've got access to 2,000 on Eclipse, and we already had a sort of 20% sign up. They're all very interested in this because the whole system is set about optimizing patient care, particularly with medication. So there's a lot of interest. However, we're recruiting off the platform as well. We also were given some more money after the NIHR said it had some more to look at something called NIHR Optimal. So this is where we fast track implementation in essence. So we've got a bit more resource from the ARC. Well, the funding will go to the ARC East, I think ARC Wessex, working with people in Liverpool to sort of supercharge the sort of rollout of this, so that if it works, the trial's positive, we can get faster integration into primary care. And then we also have a PhD funded by UEA on precise sleep, which is collecting microbiome, and a smart home sleep lab with using something called the Dreams 3 device, which is a headband. So to try and reduce the need to go to sleep services and also give the GP more information. So if we can use this system to feed into their records, that might make the system smarter. What works? Does melatonin work in this particular pattern? Should it be mirtazapine? Should they go for a walk? Is it Horlicks? Is it CBTI? Well, what's what? So having that sort of biological aspect would be quite useful. That starts alongside. And also it will, as the comment said, show if you're oversleeping, undersleeping, the specific characteristics of the sleep, which would overcome some of the problems with some of the questionnaires. Next slide, please. So I have lots of people. There are even more than this. In fact, it's going international with our advisory team, but these are the main partners. We have a significant amount of resource also from the NIHR to look at underserved groups, and we are setting up ethnically underserved groups separate, which will then have representation on the main underserved group, because during the development of this project, we learned that there are some significant cultural ethnicity issues. One example I'll just chuck in is Chinese medicine is often used in the Chinese community to help sleep. There may well therefore be appropriate routes to use Chinese medicine, and we may learn something, I don't know, but I think that's important. So we've got integrated in-house, or we're working with Chinese well-being, for example, and London Chinese community, and also tied with up north in Rochdale, we have a large group of Asian community as well, who've been working during COVID and have agreed to help us out with this project. But we're always open for more people, and I put a shout out there for any carers or patients who want to be advisors to the project, not necessarily participate. We welcome that, and other colleagues. And then if we go to the final slide, you got my email there. I've been quite successful since during the pandemic. If anyone's interested in recovery colleges, I just flag other projects, Discovery, and then we have a very large Dutch UK NIHR funded carers system called Care Coach, which is carer coaching and hybrid stuff, working sort of as another trial. The Care Coach is a program, grant Discovery is an HSDR. And then we have a very large project with social prescribing that's going to start in the autumn as well, in dementia, which may well help with some of the social aspects that we heard about, and that's importance in prevention, but we will see where that goes. Thank you for listening.